Good day, everyone. I'm Dr. Mahmoud Sheikh, nephrology consultant and World Kidney Academy instructor, and a member of the Critical Care Nephrology Scientific Board. To begin, I would like to sincerely thank my mentor, Professor Dr. Amr Husseini, for the kind invitation. And it's truly an honor to be here today among such esteemed colleagues and the professors in the field of critical care nephrology. Our session will take the form of serious interactive quizzes, each designed to reflect key aspects at the core of our critical care nephrology training. The areas to be covered today are choice of IV fluids in critically ill patients and point of care ultrasound in field of volume assessment, and the strategies of diuretic usage in critically ill illness, and the sepsis-associated AKI, dynamic measures for volume status versus the static old measures, and IV resuscitation, the proposed guidance according to the recent sepsis guidelines. Starting from the first case, I would pause for a few seconds after each quiz to collect your input. So let's keep this session a little bit interactive. Starting from the first case, a 33-year-old man is admitted to the ICU with urosepsis. The patient is lethargic, correspond inappropriately to sample questions. His blood pressure is low on 2 vasopressor agents. He is tachycardic, weight is 60 kilogram, and urine output is 1.2 liter per day. Our question is, which one of the following incorrect regarding this patient fluid resuscitation? A, fluid restriction after initial phase of resuscitation is probably going to worsen kidney function and increase mortality in patients with septic shock. B, the use of colloid solutions are expensive and multiple large RCTs have been negative, and there is an evidence of increased rates of AKI with starch, which should generally be avoided. C, normal saline when compared with balanced salt solutions such as lactated ringers may increase the risk for AKI and need for RRT and mortality in ICU patients. D, normal saline should be the fluid of choice in patients with a specific electrolyte derangement such as hypovolemic, hypochloremic metabolic alkalosis. And the last choice is, while aggressive resuscitation is usually warranted early, a transition to a conservative approach and ultimately to de-resuscitative strategy may benefit most of patients. The correct answer is fluid restriction after initial resuscitation is probably going to worsen kidney function and increase mortality in patients with septic shock. And the rationale is, there is an evidence of harm, increased rate of AKI with starch solutions, which should generally be avoided. Normal saline solution, when compared to balanced salt solutions such as lactate ringers and plasmolite, may increase the risk of AKI and need for RRT and mortality in ICU patients. Balanced solutions resulted in improvement in patient and renal survival in 1% absolute with 1% absolute reduction in composite outcome of death, and the need for RRT and persistent doubling of creatinine level at 30 days, particularly in patients having AKI. Saline solutions should be fluid of choice in patients with a specific electrolyte derangement, such as hypovolemic, hypochloremic metabolic alkalosis, and traumatic brain injury patients. The pathophysiology underlying the purported negative effect of saline solution on kidney is related to high chloride content. A proposed mechanism includes reduced GFR through activation of TGF, triggered by increased chloride delivery to macula densa. Vasoconstriction caused by chloride-induced thromboxane release increased inflammatory cytokine expression that was induced by acidosis. Volume overload in patients with AKI, aortic and sepsis and critical illness is independently associated with progressive decrease in kidney function, lower odds of renal recovery, and increased mortality. The negative impact of fluid overload in kidney function may be due to venous congestion, which can lead to venous hypertension, and renal venous hypertension and increase renal interstitial pressure, which lead to reduced renal blood flow and GFR. Fluid restriction after the initial resus phase improved kidney function and was associated with trend toward decreased mortality. While aggressive resuscitation is usually warranted early, by 36 to 48 hours, a transition to a conservative approach ultimately be a de-resuscitative strategy and may benefit most of patients. This photo illustrates the concept of balanced solutions, showing that normal saline may have high chloride content, despite its name is not truly normal and its osmolarity differ from that of plasma. And this table highlights the key facts comparing balanced solutions with normal saline, along with important outcomes from salted and smart trials. In salted trials, the outcome was no difference in hospital-free days between balanced crystalloid and normal saline, and there is lower incidence of major adverse kidney events within 30 days. But SMART trial reveals that lower incidence of major adverse kidney events within 30 days in favor for balanced crystalloids. Case 2, 65-year-old male with history of hypertension, type 2 diabetes and CKD stage 3, admitted to the ICU with acute shortness of breath, orthopnea, significant reduction in urine output over the past 24 hours. He reports 5 kilogram weight gain over the past week despite adherence to low sodium diet. Medication was lisinopril metformin for the mild 40. Physical examination revealed blood pressure was high, heart rate 110, was tachypneic, saturation 88 on room air, and there was bilateral coracoid lung auscultation, jugular venous distension up to 8 centimeter above the sternal angle, 3+ pitting edema in both lower limb extremities. Lab revealed serum creatinine 3.8 and baseline was 1.8. Potassium 5.2 and BNP was elevated 1,200. ABG revealed metabolic acidosis increased CO2. Chest X-ray revealed bilateral pulmonary edema and cardiomegaly. Which one of the following POCUS finding would most likely indicate hypervolemia as a cause of patient symptoms? Is it dilated IVC diameter more than 1 centimeter with more than 50% respiratory variation, or enlarged IVC diameter more than 2.5 with less than 20% respiratory variation, or normal size IVC diameter with more than 50% respiratory variation, or decreased LVEF more less than 40% with apical ballooning, or moderate pericardial effusion with right ventricular diastolic collapse? And the correct answer is enlarged IVC more than 2.5 centimeter with less than 20% respiratory variation. History of hypertension and diabetes in CKD in this patient, alongside with the physical finding of GVD, bilateral crackles, and peripheral edema strongly suggest volume overload. Elevate BNP to 1,200, pulmonary congestion, chest X-ray support the diagnosis. POCUS finding and critically to confirm hypervolemia and guide management. An IVC diameter more than 2.5 centimeter is indicative of elevated CVP, which is a hallmark of hypervolemia. This finding is consistent with the patient clinical presentation. Less than 20% respiratory variation suggests the patient is unable to generate sufficient changes in intrathoracic pressure despite during respiration, which is often seen in states of fluid overload or right side heart failure. A normal IVC with significant respiratory variation is typically seen in euvolemic patients, while decreased LVEF suggests systolic failure. It doesn't directly assess the volume status. Apical ballooning is a feature of Takotsubo cardiomyopathy, which is not supported by the clinical context. Pericardial effusion with right ventricular diastolic collapse is a sign of cardiac tamponade, life-threatening condition, need immediate pericardiocentesis. This is not consistent with the patient presentation of gradual volume overload. And this, there is correlation between right atrial pressure and the IBC diameter with the collapsibility index, showing that the larger diameter is associated with less collapsibility. Case 3, 65-year-old female with history of hypertension, type 2 diabetes, CKD stage 3, admitted to the ICU with septic shock, secondary to urosepsis. She was febrile, hypotensive, confused, vitals during while admission was blood pressure critically low, tachycardic, tachypneic, and feverish. Oxygen saturation was low in room air. Lab result revealed creatinine increase from baseline to 3.6, potassium 5.2, lactate increase also to 6.5, white blood cells 18,000, procalcitonin 12, EPG revealed metabolic acidosis. The patient was intubated for airway protection and started on mechanical ventilation. She received 2 liters of normal saline bolus and started on norepinephrine infusion, titrated to maximum dose of 0.5 mic per kg per minute. Despite this, her MAP remains at 55 and her urine output is 0.5 milli per kg per hour. She has bilateral basal crackles on lung auscultation. The question is, what's the most appropriate statement regarding diuretic use in this patient? A, administer furosemide to convert oliguric to non-oliguric AKI. B, the use of diuretics in septic patients doesn't improve their outcome. C, use diuretics only if hyperkalemia develops. D, administer thiazides for better diuresis. E, start spironolactone for its anti-inflammatory effects. And the correct answer is the use of diuretics in septic patients doesn't improve their renal outcome. The primary goals of management to treat the underlying infection and optimizing hemodynamics, prevent further renal injury. Diuresis is often considered in oliguric AKI to increase urine output, but their use is controversial, not supported by evidence in critically ill patients. Diuretics, like furosemide, can cause volume depletion, reduce renal perfusion, and exacerbate AKI. They don't improve renal recovery, maybe improve the general condition of patient regarding the congestion and volume overload, but regarding renal recovery, no evidence for that. Studies have shown that diuretics don't reduce mortality or the need of RRT in AKI and may worsen renal function. Converting oliguric to non-oliguric AKI with diuretics doesn't improve outcomes and may worsen renal function by causing volume depletion. This practice is not supported by evidence and potentially harmful. Diuretics are not first-line therapy for hyperkalemia. Other interventions such as calcium gluconate, insulin glucose, or the new agents for hyperkalemia are preferred. Thiazides are less effective than loop diuretics in AKI and are not recommended for management of oliguria in critically ill patients. Spironolactone, potassium-sparing diuretics that can cause hyperkalemia, particularly in patients with AKI, is not indicated for AKI or septic shock. This option is contraindicated and may worsen hyperkalemia. This algorithm outlines the indication and the initial choice of furosemide, defines diuretic resistance based on the response after 2 hours, then details dose escalation and the addition of sequential blockade in case of resistance, and finally specifies drug choice for patient with COPD, maybe carbonic anhydrase inhibitor or thiazide-like diuretics in case of acute heart failure. Case 4, 70-year-old female with history of type 2 diabetes, CKD stage 4, admitted to ICU with septic shock, secondary to diabetic septic foot. On admission, she was unconscious. Blood pressure was low, critically, heart rate tachycardic. She was also tachypneic and feverish, saturation 58 on room air. Lab results revealed serum creatinine 5 and baseline was 2. Potassium 5.8, lactate 5.5, white blood cells 20,000, procalcitonin 12, and metabolic acidosis. The patient is intubated for airway protection and started on mechanical ventilation. She received 3 liters normal saline bolus that remains hypotensive and requiring inotropes infusion to maintain MAP more than 65. Her urine output less than 0.3 milli per kg per hour, and she has bilateral lung crackles. The question is, which intervention is most appropriate in managing sepsis-associated EKI in this patient? A, early initiation of RRT, or aggressive IV fluid resusc with large volume crystalloid infusion, or administering vasopressor while avoiding additional fluids, or treating sepsis with broad-spectrum antibiotics and conservative fluid management, or high-dose steroids and as a first-line therapy. And the correct answer is treating sepsis with broad-spectrum antibiotics and conservative fluid management. The key drivers of sepsis-associated EKI include systemic inflammation, hyperperfusion, and endothelial dysfunction. Early administration of appropriate antibiotic is critically in septic shock to control the infection and reduce systemic inflammation, which is a major contributor to EKI. The surviving sepsis campaign guidelines emphasizing the importance of initiating antibiotic within 1 hour of recognizing septic shock, with more details in this point. While initial fluid resusc is essential, excessive fluid administration can lead to fluid overload or worsening pulmonary edema or renal congestion, or further exacerbating the EKI. RRT is indicated for life-threatening complications of EKI such as severe hyperkalemia, uremia, refractory acidosis, or fluid overload. Early RRT initiation without clear indication doesn't improve outcomes and may expose the patient to unnecessary risk. Vasopressors are necessary to maintain perfusion pressure in septic patients, but they should be used in conjunction with appropriate fluid management, not as a replacement therapy. Steroids are not the first line for septic shock unless the patient has adrenal insufficiency or refractory shock despite adequate fluid resuscitation or vasopressor. This image highlights the timing of antibiotics used in sepsis, indicating when shock is present or absent. If the patient shock is absent and sepsis is possible, we can administer antimicrobials within 3 hours, not within the first hour. But if the shock is present and sepsis is possible, we should give the antibiotics, the appropriate one, within first hour of recognition. Case 5, 36-year-old woman who is transferred to the ICU from operating room after underlying laparotomy for a ruptured appendix and peritonitis due to fecal contamination. Patient received 2.5 liters of IV fluid during and after the procedure, along with antibiotics. Central venous line was placed and the patient was started on phenylephrine infusion. You are considering the benefit of giving more fluids and would like to assess her volume status before doing so. Which of the following statement regarding fluid assessing in patient fluid responsiveness is most accurate? A, dynamic parameters of fluid responsiveness can be checked in this patient since she is on vasopressors. Pulse pressure increase in response to passive leg raise is a reliable method for checking fluid responsiveness. Physical examination remains the gold standard for assessing fluid responsiveness. Pulse pressure variation or stroke volume variation are static parameters to assess fluid responsiveness. Static parameters are superior to dynamic parameters in assessing fluid responsiveness in recent literature. And the correct answer is pulse pressure increase in response to passive leg raise is a reliable method for checking fluid responsiveness. For adult patients with sepsis or septic shock, the SCCG suggests using dynamic measures to guide fluid resusc over physical examination or static parameters alone. Heart rate and CVP, systolic blood pressure alone, are poor indicators of fluid volume. Dynamic measures demonstrate better diagnostic accuracy and predicting fluid responsiveness compared with static techniques. Dynamic measures such as passive leg raising, CO fluid challenging against stroke volume, systolic pressure or pulse pressure, or increased SV in response to changes in intrathoracic pressures. Dynamic assessment guide fluid therapy was associated with reduced mortality, ICU length of stay, and duration of mechanical ventilation. And this is the comparison between static and dynamic markers for assessing fluid responsiveness, the old one of practice and the new practice, helping to determine if the patient is hypervolemic or not. Case 6 and last one. 66-year-old woman with past medical history of SLE and hypertension, CKD, recent right hip arthroplasty, is seen in emergency room with septic shock due to lower limb extremity thrombolysis. In ER, she will have increased lactate level and leukocytosis, transaminitis. She started on ceftriaxone and vancomycin. Culture was sent. She received 1.6 liter of IV fluid in emergency room. Current blood pressure is 83/50, MAP 61, heart rate 105. She weighed 113.5 kilogram. She's drowsy but arousable. Hair white blood cells 13,000, lactate level 3.4. The question is, what should be the most appropriate next step in management of this patient? Give 1.8 liter fluid bolus and start epinephrine, norepinephrine, if MAP remains below 65. Give another 2.8 liter fluid bolus and start norepinephrine if MAP remains below 65, or give more fluids to complete 30 cc per kilogram total fluids and add dopamine, or place central line and give more fluids only if CVB is less than 8, or start norepinephrine along with vasopressin to keep MAP more than 65. And the correct answer is give another 1.8 liter fluid bolus and start norepinephrine. The total amount of fluids that should be administered in septic patient for proper resuscitation is still debated, but SSC guidelines suggest treating septic subjects at least 30 ml per kg of IV fluid crystalloid within the first 3 hours. This patient weight is 113.5 kilograms, so her initial fluid bolus should be around 3.4. Fluid resuscitation should be guided by dynamic measures such as pulse pressure, cardiac output variation in response to fluid bolus, or passive leg raise rather than CVP. The SSC recommends MAP target of 65 and indicate norepinephrine as the first choice drug. Vasopressor can be initiated simultaneously while fluids are being given. This is the initial resuscitation algorithm. We should assess the volume of resuscitation history upon the history and the cardiac dysfunction if he has previous cardiomyopathy or stenosis or pulmonary hypertension, and if they have bedside echocardiography. Then we will manage according to history examination if we give large volume resuscitation or moderate volume or low volume. And this is the guidelines for vasoactive agent management from the Surviving Sepsis campaign. First line use of norepinephrine as first vasopressor for the patient on septic shock. The mean MAP target is 65. Then consider invasive monitoring of arterial blood pressure. If the patient central line is not yet available, so consider initiating vasopressor peripherally. If MAP is inadequate despite low to moderate dose norepinephrine, consider adding vasopressin. If cardiac dysfunction with persistent hypofusion is present despite adequate volume status and blood pressure, consider adding dobutamine or switching to epinephrine. Thank you so much for listening. It was just 10 minutes, so I was in a hurry to present these 6 cases. We are waiting. Your time is running to join our critical care nephrology fellowship. Thank you so much.